All right, thank you for joining us today. And we're going to be talking about skilled nursing facility review findings. My name is Mary Sue Gardner. I'm a registered nurse on the Provider Outreach and Education team, and I am going to be your facilitator for today's event. I'm also joined today by members of Provider Outreach and Education, as well as Medical Review, who will be assisting with any Q&A for today's call. The objective of today is to focus on mitigating audit risk and those findings that you may get if you are selected for medical review of your skilled nursing facility services. And we're going to accomplish that today by really going through the coverage criteria. We're also going to review documentation guidance, and then we're going to end with a discussion of some of the most frequent findings we continue to see in our medical review department upon medical review. Before we start discussing those review findings, let's briefly talk about the basic coverage criteria. Because if the coverage criteria is not met and not documented, then it's going to result in a denial. Let's start with some general requirements for skilled nursing facility or SNF services. These are the mandatory requirements that must be met for a skilled stay to be considered for coverage by Medicare. So in order for Medicare to pay, the first thing is that the patient must be admitted as an inpatient to the skilled nursing facility to receive skilled services. So this admission must be after that patient has had a 3-day qualifying hospital stay. We're going to revisit this again in a little bit, but it's easiest to think about this as 3 midnights as an inpatient in a hospital. So was there behind in a bed for 3 midnights? So continuing on with these general requirements, the admission to the SNF must occur within 30 days after the discharge from that inpatient hospital stay, so that qualifying hospital stay or QHS. And finally, that admission for skilled services into the SNF must be for a condition that was either A, treated in the qualifying hospital stay, or for a condition that arose in the SNF for treatment of a condition for which the beneficiary was previously hospitalized. Now let's discuss what the general qualification criteria for skilled nursing facility stays are. So first off, the BNI must require skilled care on a daily basis. Skilled care on a daily basis is medically necessary health care that's provided by or under the direct supervision of a licensed professional, like an RN, an LPN, or a therapist. And it's designed to manage care, to observe and make observations of the care, to treat chronic conditions or acute recovery needs. And it's generally required 7 days a week for nursing services, or that can be met in 5 days a week for therapy services. And it includes intensive services like IV management, specialized wound care, even rehabilitative therapy. So when we think about skilled care and the skilled staff, and if you are one of these skilled providers, think about when you go to document, why does this service need me? My skills, my expertise, my licensure. Can someone other than me perform this service, observe this service, manage this service, treat this service, etc.? If someone less than you, less than your licensure can do it safely and doesn't require you at all, then perhaps it's not a skilled service. So you always want to be thinking about that and documenting towards that when you are documenting your services. So as we move on, these services can only safely and effectively be provided on an inpatient basis in a skilled nursing facility. Again, if the services don't require that inpatient need, then it may not meet this qualification. The services must also be ordered by a physician as well as certified by a physician or a qualified non-physician practitioner. And remember, that's when it's allowable by your state practice acts as well. So just because Medicare says a non-physician practitioner can do these things, you have to also make sure it's okay for the state that you practice in for that non-physician practitioner to act in that capacity. And then finally, the services must be performed by or under the direct supervision, again, as you as a licensed personnel. So that's where I really encourage you, go back and think, does it need me? Does it need my licensure, or can someone less than me do it? So for more information of what constitutes skilled level of care, you can refer to the Benefit Policy Manual, which is 100-02, Chapter 8, Section 30, and Jennifer is going to, if she has not already, place a copy. She has already placed a link to that chat, or link to that in the chat for you. Tongue-tied today. All right. So using the general criteria coverage that we just discussed, and how a beneficiary must have a qualifying hospital stay before coming to the SNF. And again, I encourage you to think of that as 3 midnights in the hospital. So their benefit period for skilled nursing facility stay starts with that qualifying hospital stay, which means they need to have that qualifying hospital stay. It needs to be within 30 days of coming to the skilled nursing facility. Once they are appropriately admitted to the skilled nursing facility, Medicare will pay for appropriately needed skilled services for up to 100 days. Now, that does not mean everyone automatically gets 100 days. That means when reasonable and necessary, they have anywhere from 1 to 100 days available that could be used and paid for or partially paid for by Medicare. The benefit period is going to continue until that beneficiary is actually facility free for 60 consecutive days, or if they remain as a resident in your place as a nursing facility and they're no longer receiving skilled level of services for at least 60 days, then that would qualify as well. But remember, they have to no longer be receiving skilled services if they're going to remain in your facility. That person then only can go back to a SNF or go back into skilled services if they have a new 3-day qualifying hospital stay. So remember, if a patient continues to receive a skilled level of care, and they've exhausted their 100-day benefits, and they remain in the facility receiving a skilled service, the SNF must continue to report this in their billing. That beneficiary is not going to be eligible for another benefit period until they either A, leave that facility for 60 days, or B, they drop below the skilled parameters. So that below that 7 days for nursing and 5 days for therapy. And this has always been an issue with some of those patients that are receiving nutrition, so parenteral or enteral nutrition, and they're above those parameters set by CMS, and they continue to receive that skilled service, and it just goes on and on for sometimes the lifetime of that patient, then they don't qualify for a new benefit period because they never drop below that skilled level unless they happen to go home for greater than 60 days. All right, let's take a closer look and talk about this 3-day hospitalization. So we've hit on this briefly a few times already, but let's talk specifics. So the SNF benefit period, again, starts with that 3-day qualifying hospital stay. That is 3 consecutive days in one or more hospitals. Like I said before, the easiest way to think about it is if that beneficiary was in an inpatient bed for at least 3 consecutive midnights. And counting your 3 days, the day of admission counts, but the day of discharge does not because they'd be gone before that midnight. That's why I always say think about it, you know, about inpatient and 3 midnights. And has that beneficiary been in that bed at the midnight census taking 3 midnights in a row? Remember, time spent in observation or outpatient services do not count towards the inpatient stay. Again, it commences with the first day of admission, so that's your day 1. A little closer look at the 30-day transfer. Remember I said that under the general requirements that the patient must have come to the skilled nursing facility within 30 days of that qualifying hospital stay. So since day of discharge doesn't count, the 30 days of counting starts with the day following the actual hospital discharge or the discharge date from the hospital. And it continues until that patient is admitted to the SNF for the required covered level of care. So when counting your 30 days, remember that starts the day after they're actually discharged. There is a clause in the Medicare regulations for when there is a medically appropriate exception. And this means there's going to be an elapsed period of more than 30 days, and it is permitted for the SNF admissions when the patient's condition makes it medically inappropriate to begin an active course of treatment in the SNF, like immediately after that hospital discharge or within that first 30 days. But the caveat to that is it has to be medically predictable by that physician at the time of discharge that that person is going to require a covered care within a predetermined amount of time. So the fact that the patient enters the SNF immediately after discharge from the hospital for either covered or non-covered care doesn't necessarily negate coverage at a later date, assuming that all the subsequent covered care was medically predictable. So again, this is an exception to the rule, and it has to be documented by your physician. So the best example I can give of that, and the easiest way to think of it is your beneficiaries that are non-weight bearing, that leave the hospital stay and they're still in a non-weight bearing status, let's say for 5 weeks before they're able to get therapy services or participate actively in therapy for whatever their illness or injury happens to be. And because of that, the physician has said, you know, this person is not to start therapy. They're supposed to be non-weight bearing. They don't have any nursing services that need to be done. But we know after 5 weeks, they can bear weight on that extremity and they are free to participate. So in this case, as long as the physician documents it, we would have a medically appropriate exception. But again, I'm going to refer you to the Benefit Policy Manual, Chapter 8, where we were before, but this time you're going to want to pay attention to sections 20.2.2 and 20.2.2.1. So Jennifer placed that in the chat for you. Again, it's the same link as she put in for slide number 5, just a different section. So as we move on, let's talk a little further about the spell of illness, or better yet, I like to refer to it as a period of wellness. And we've kind of spoken about this briefly. So when would a patient qualify for another course of skilled nursing facility care? And we said in order for that patient to qualify, they must have not been in an inpatient skilled level of care for at least 60 days. And that starts the day after discharge. And the best way to think of this is, have they had a period of wellness, either facility-free or staying within the facility but not receiving skilled level of care for at least 60 days. If they've met these 60 days and then they have another qualifying hospital stay, then they are admitted to the SNF or readmitted back to the SNF, then they can start a new spell of illness and generate a new benefit period, which again pays up to 100 days. Now remember, I keep saying pays up to 100 days. And that doesn't mean that all beneficiaries automatically get 100 days. It means they have 100 available days of skilled services that Medicare will pay or partially pay. And that also doesn't mean it's only appropriate to keep a patient in skilled for 20 days, because the first 20 days are the days that Medicare pays full, and then the next 80 days are co-pay days where the beneficiary is responsible for a portion of their stay. If they continue to need skilled services, they should not be kicked out of the SNF or dropped from services because the facility is not going to get 100% payment. We have seen that happen in more cases than I would like to say, but it's not appropriate if the patient continues to need care. Now, if the patient and family decide to leave because they can't afford those co-payment days, that's whole different. But again, we shouldn't be keeping patients to 100 days just because, and we shouldn't be dropping patients after 20 days because we're afraid we're not going to get money. All right. Now I want to make sure that you know, as part of the general requirements for SNF services, that physicians must be involved, and physicians must certify and recertify the need or the continued need for those skilled services. So certifications and recertifications must be signed by your physician or your non-physician practitioner. Non-physician practitioners are allowed to sign certifications and recertifications if they are not directly employed by the SNF. So if their paycheck is not coming from the skilled nursing facility, but instead coming from like the physician, then they can do that. But if you are paying them, then they cannot be the ones to sign. The physician must order admission care and certify the initial care as well. So orders for admission are not certifications, so they can't be, they're not routine. A routine order is not, you know, a certification. Medicare doesn't require any kind of specific form to be used for your certifications or recertifications. However, we have seen some standard type templates that have that certification, and then they have the recertification spots under it. And there's the reminder date slots that show up like on the left-hand side. And there's a specific place for the physician or non-physician practitioner, signature lines, etc. Pretty much most of the ones that we see take a similar type format. But these, again, are not required certification or recertifications by Medicare. So a facility can choose to get those and keep those in any format that they wish. A few other things about certifications and recertifications. They must be signed timely. So in the upcoming slides, we're going to discuss timing a lot because this could result in denial if you mess that up. However, there are provisions for delayed certifications in the regulations as well. And this is in the event that there's an oversight in getting the certification or, something accidental or oversight. A little general information about recertification. So your recertifications that's a must contain the reason for continued skilled care, not just continue PT or OT, but they must contain the information of why PT or OT must continue. And then you can turn around and apply that to any nursing service as well. So it's not just enough to say continue wound care, but why that wound care needs to continue, what we're trying to achieve. So recertifications must also contain an estimated period of time that your patient is to remain in the facility. It may be close, it may not. I mean, none of us have a crystal ball. So if a physician estimates a period of time and that estimate is not met, that's okay. They just, in their best opinion, in their best foresight of the patient and care of the patient, how long do they think this person's going to remain in the facility? And that also takes us to what are their plans when it's appropriate for home care or any aftercare for this patient. So as we continue to recertify, we need to be thinking of where is this patient going to go? How long do we think we still need to provide services? And then are they going to stay here? Are they going to go home? And if they're going home, what kind of services are they going to need there? Now, when it comes to timing, there are some timelines that are very important to know and remember, because if you miss these timelines, you are not in compliance with regulations, and therefore you may have dates that are not covered for your services, because if you miss the timelines, your patient then really is not under the care of a physician for those dates that you missed. So when it comes to the initial certification timing, that is due upon admission, or the regulations say, or as soon thereafter as is reasonable and practicable. But it has to be done by the 14th day of the stay. So that means the initial certification and the first recertification can be done at the same time. However, your first recertification must be done by the 14th day. So that's your drop dead date on your first recertification. Now, following that, subsequent recertifications must be made on or before every 30 days from the prior recertification date. From the prior recertification date. So those forms that we previously talked about that are not required but commonly used, those certain recert forms, those forms generally contain a spot, generally on the left-hand side, where you can put those reminder dates for your physician, non-physician practitioner. Remind them of when they must sign. However, if you fill in these in advance and just based off the admission date and then have all the reminders already filled out all the way down, and then that physician or non-physician practitioner signs early or late, you've thrown everything out of whack. So you shouldn't be populating in past the 14th day until you know when that physician signs that 14-day recertification. And then you set 30 days from whenever they signed the 14th day. And then for the next 30-day block, then you go by 30 days past whenever that last signature is. Because again, we've seen it far too many times where someone writes in those reminder dates based on the admission date, and then the physician signs early or signs later, or whatever the case may be, and everything gets thrown out of whack. And unfortunately, we've had to make denials in some of those cases because the physician's signature, there was no proof, of patient being under the care of a physician for those few days in question. So you could potentially lose money. So I really wanted to make sure I hit on that because it's a common issue that we see and a cause for denial. And again, basically, you're not proving that beneficiary was under the care of a physician for those days that you're out of compliance. So please do not fill in a reminder date for the next recertification until you have a signature and a date on the last one. Then you set your next reminder based on that signature date. Now we're going to shift gears a little, and we're going to talk about how to support this coverage criteria in your documentation. We have several slides here on documentation. So let's start with the required components of documentation that are required to be completed, to be part of your chart, and to be supplied to your MAC or to any federal review entity in the event a review is requested. So let's start with the look back information. In skilled nursing facility services, especially upon admission and determining your PDPM HIPS codes, look back information can go into services that are rendered in the hospital. So things like IVs, IV medications, etc., that were provided in the hospital, they play a huge part in determining and setting your payment rates. So make sure your documentation contains that look back information, especially that information from that qualifying hospital stay. So your MDS coordinators need that to appropriately determine your dates, set it to get you the best payment rate, to get the information. And so you have to get that information from the hospital to support things like IVs, whatever we're given. And you need to supply that to us so we can also see that your coordinators have made those, set those dates appropriately and that HIPS code is appropriate. Next will be your admission record. So those records generally contain the diagnoses and the conditions that required skilled care. This may be part of the provider's progress notes or histories and physicals as well, contain some of this admission record information, as well as the nursing overall admission records. Besides progress notes, we need the provider's orders. Orders help support all the services to be provided and support the need for your skilled services. When it comes to nursing, so under nursing, basically anything the nurse documents on should be submitted if you're requested for review. That includes things like flow sheets, treatment records, progress notes. Remember, your documentation must support that HIPS code that's reported. So we're going to comb through and look at all of the nursing notes to support that daily skilled service. And then finally on this slide, any social service or case management documentation. So this could include progress notes from them, or any plans for post-skilled nursing facility care, any overall plans of services, of consults, of equipment that's going to be needed for your patient. So as we move on to the next slide, I'm going to continue on here. Nutrition records. This can include any dietary notes, or any dietary progress notes. I&O sheets, meal tracking, dietary restrictions like certain types of diets or certain consistencies of diets, any of that we are going to want to see as well. Medication administration records, IV medication administration records, if those happen to be kept separately. Some places just call them MARS, some have IV medication administration records. If the patient has any type of monitoring that goes along with medication administration, we would need to see that as well. So for instance, your diabetic patient that's on a sliding scale insulin, we'd want to see those blood glucose results to support the appropriate medication administration. When it comes to therapy basically we need everything. And that specifically includes the initial evaluation, regardless of the dates of service that we're reviewing. So if therapy started in February and we're reviewing May, we need the documentation to support the start of care, which includes that initial evaluation and plan of care, as well as any documentation to support the dates of service that are under review. That includes your daily treatment records and progress notes, even if they're in the form of logs or grids for your daily treatment records. Or if you have a combination of both logs and grids and others, include all of it. Also, like I previously mentioned, any physician certification and necessary recertifications. And then finally, any patient care plan records, regardless of who they are made by. I've alluded to this already, but every service that sees your patient has some type of plan for your patient. That includes nursing, social services, dietary, therapy, prosthetics, orthotics, etc. The list goes on. So you need to make sure that each skilled service is keeping their own plan of care and that we are getting it to review if we need it or if we request a review. As we move on, we need to see any diagnostic records, such as any radiology reports, any laboratory reports, etc. And then a hard copy of your MDS. Now, this is important because we need to verify what you have on file versus what you locked into the repository versus what you requested reimbursement for on your bill. As we complete a review, we're also recreating your MDS based on the documentation. So if it's not documented, it's not done. We can't put it on your recreated MDS if we can't find it supported in your documentation, which that could result in a different payment based on what we did actually find, which usually is a down-coded payment. Finally, signatures by all skilled service providers, but especially by the physician. And then along the lines of physician signatures, any applicable attestation statements for any kind of missing or illegible signatures. And then finally, any signature logs or keys. Those should be submitted so we know who provided this service or we know who initials belong to. Very often on some of the therapy grids, you'll see there's a place and you can put the provider's, initials in it, who that service provider was for that day. And we don't know if it was the actual PT or an PT assistant, so we need to see those signature logs if we need to match those up. All right, you can further find documentation guidelines on our website, and that's under medical review, and you go to Part A, it's medical review, TPE, and skilled nursing facility. And I am just going to put a quick link into the chat that will take you straight to that information if Jennifer didn't already do that. Sometimes I, get my cart before my horse and I ask Jennifer to do something and then I do it myself. This isn't very nice of me. All right, so now as we round out, let's talk about these common review findings that we continue to see upon review. And we're doing this in an effort to help you avoid these findings if you find you are ever selected for a review, or maybe you're currently under review, and you just want to make sure you're avoiding these things going forward. You're going to see in the upcoming slides that I have the SNF reason code statement document codes listed at the title of this slide. Now, these are the standardized reason code statements for skilled nursing facility services to really ensure that providers and suppliers have a more consistent experience and that their claim denials are easier to understand. These are standard denial reason codes that all MACs, the RACs or recovery auditors, the SMRC, short contractor, etc. We all use the same one. And Jennifer put a link to those reason code statement, that document into the chat for you to review. We're going to start with the denial reason code SN000. So this code is for insufficient documentation to support the 3-day qualifying hospital stay. And there was no waiver indicated. So in other words, or the AKA, there's no qualifying hospital stay listed. We can't find that information. How do you avoid this issue? Well, you can avoid it by ensuring that the documentation supports your qualifying hospital stay, making sure that your billers include that necessary 70 span on your bill, especially if the hospital hasn't dropped their bill yet. Very often the SNF may drop their first bill before the hospital has even dropped their hospital stay bill. So you want to make sure that you have a way that our reviewers know what that hospital stay and that qualifying hospital stay was, or that 70 span on your bill. Make sure that you consider what that 3-day qualifying hospital stay means. Again, think of it as 3 or more midnights in an acute hospital. That's part of your coverage criteria. All right. The next most common issue, the SN300. So this denial reason code is defined as the documentation submitted did not include the required certain research for the SNF stay. So there's no AKA for this because it's pretty self-explanatory. So how do you avoid this? It's by making sure that all certifications and recertifications are done, that they are completed timely, that they are signed, and that they are part of your documentation that is submitted for review. In the footer of this slide, I've also placed some links to some various regulations that have to do with certification specifically. The next common error is the SN600, which is defined as the doc submitted does not support the level of service as shown on the claim. The HIPS was recoded to reflect the MDS changes supported by the doc submitted. So AKA, the doc and the bill do not match. And WPS recoded your HIPS code to match what we did find in your documentation. So you can avoid this by ensuring that your doc supports your HIPS code bill before you submit that to Medicare. And, you know, kind of talking in advance, make sure that if you submit your MDS to the repository and you happen to get any errors, make sure those errors are corrected before you bill Medicare. Sometimes, you know, things can be accepted, but they still come up with error. And if you don't pay attention to those errors, it could cause you issues if we look at what's locked into the repository versus what's billed, et cetera. And the final most frequent denial that the reviewers are making is the SN603. And that means the claim was denied because there was no MDS found in the repository. Again, no otherwise known as on this because it's pretty straightforward. But again, avoid this by ensuring that your MDS has been entered into the national repository prior to your request for payment. And you need to, again, verify any transmission errors and correct any submission transmission errors that may bounce back to you. And sometimes if you receive an error message and you don't correct it, like I said, it's gonna affect future claims. All right, so at this time, I am going to look over, and I do not see any questions in the chat, which is fine. I'm going to proceed in the interest of time, but if you have a question, go ahead and throw it into the chat, and if we don't get to it, I will respond to it via email. All right. One too many. All right, we value your opinion. We want to hear from you on how we did on this event. So the survey for this event really only takes a few minutes to complete. There are several parts to it, and I will ask you if you want to continue. And I do encourage you to continue at that point. But we want to give you the opportunity to go ahead and take that now while this webinar is still in progress. This is your opportunity to tell us also what additional education would you like in the future. So many of the educational events that we provide are a direct result of that, but you don't get to put that information in unless you take the second half of the survey. So we do require you to take it and take it to, its completion. And then I'm going to check again, and I don't see any additional questions, and I show that we are right at the end of time. So finally, if you think of any questions regarding this event, please don't hesitate to email those to us at wps.gha.education@wpsic.com and send those within the next week. Please don't send any PHI or PII. And remember, we do not have access to the claims processing system. So if you need to find out about a specific claim, you will need to take those questions to customer service. So remember to check the notes section of the slide deck for any additional information that you may want to know. And I see Lisa says her system will not let her take this survey. You're going to get a thank you email, Lisa. It might already be in your inbox, and that also has another link to the survey, and that's a different way in which you might be able to take it. So try using the link in the thank you email. So on behalf of Jennifer and myself, as well as Medical Review, we want to thank you for your participation in today's event. This concludes our webinar, and you may now disconnect.